Assalamu alaikum. Welcome to the Zoom meeting. So today we're going to start with the agenda as listed. The team will be presenting with Dr. Das as a moderator. The first topic will be about the dental implant. So,
hi, Dr. Nadir.
hello.
This is Marina Das, yes.
Dr. Marina, go ahead.
Yeah, I'm the leader of the TAN group, and my team will be presenting today. Okay, can I share my screen? I am unable to. Okay. So the topic for today's presentation is dental implant resources by Dr. Wala and Dr. Muram. Neuropsychiatric disorders post-stroke will be presented by me, Dr. Marina Das, and the PRISMA statement by Dr. Milad Munir. So, okay. So I believe Wala is here. Wala, can you hear me?
Yes, I hear you.
Okay.
Yes, we hear you.
Okay, Wala. I am making you the host and you can share your screen. Okay.
All right. Okay.
Give me a moment.
Okay. Assalamu alaikum, everyone. Assalamu alaikum, Dr. Nadir. Eid Mubarak, all of you. I want to introduce myself from the beginning. My name is Wala Hassan. I'm in a dental group. I will be present today the dental implant topic with my colleague. Her name is Mayra, but I don't know if she's here or not yet. I should start right now.
Yeah, Dr. Wala, you can present your slide.
All right. Just
Given you access. Yeah.
Okay. Okay, just give me 1 second. You can see my screen right now?
Yes, please go ahead.
Okay. So today I will start to present the dental implant. I will go through the content. First of all, I will talk about introduction, osseointegration, classification of the dental implant, implant component, the treatment plan, surgical procedure, and the prosthetic phase, complication, and conclusion. Introduction. Dental implant is an artificial titanium fixture which is placed surgical into the jawbone to substitute a missing tooth and its root as well. Dental implant, they aim at the functional and aesthetic rehabilitation of the patient affected by the complete or the partial edentalism. The osseointegration is it's a Swedish orthopedic surgeon. His name is Prof. Frank Mark. In 1952, accidentally discovered osseointegration. When the pure titanium came into contact with the living bone tissue, the two literally grow together to form permanent biological adhesion, and it's also called functional ankylosis. There is some factor affect the successful of the osteointegration. The first is the biocompatibility material, the titanium, either commercial, pure, or in the certain alloy. Primarily implant stability, it should be precisely adapted to the prepared bony site. A traumatic surgery to minimize tissue damage. Immobile and indistribute the healing phase. A titanium biocompatibility is due to its surface oxide. When exposed to the air, it forms a dense 4 nanometer layer of the titanium dioxide, chemically stable and very corrosion resistant. For grade commercially pure titanium differing with the percentage of the trace impurities in the metal, the greater the contaminant, the harder the metal. Grade 4 copper titanium commonly used for the dental implant. Grade 5 titanium alloy, it's Ti6A14V, offer equal biocompatibility, but it's better tensile strength and fracture resistant than the commercial pure titanium. And the other type is the zirconia. It is similar in biocompatibility as well, improved aesthetic form, and it's the fracture resistance of the zirconia, it's low. Can be used at only one piece. There is a several step of the osteointegration where the bone quickly form in the gap between the implant and the bone. It has a low biomechanical capacity. The occlusal load should be controlled. After 1 to 2 months under effect of the load, the wave of the bone will slowly transform into the lamellar bone. Another thing is implant tissue interface. The implant and bone interface is the glycoprotein layer, and the bone is absorbed on the implant surface with help of the adhesive of the macromolecules like the fibronectin and laminin. They are bonded to the metallic oxide layer on the titanium by the covalent bond or ionic bond or van der Waals bonding. Implant connective tissue interface, it's a gingival fiber. From the attach is strong enough to withstand the occlusal force and microbial invasion. So the implant epithelial surface, it's epithelial attached to the implant surface through the hemosomes and the glycoprotein and considered as biological seal. Its form, the sulcus depth should be 3 to 4 millimeters. And here on the left side of the screen, this is the natural tooth, and the other side, the right side, this is the implant tooth. So from the start, there is a natural crown of the tooth, and then the red area, this is the gum tissue, and there is a fiber holding the gum tissue, and then beneath that there is a periodontal ligament, and then there is the bone. On the other side, the right side of the screen, there is the artificial crown, and there is the implant, and there is a different part of the implant itself, and there is the gum, supposed to be the implant embedded inside the gum, and there is the screw type of the implant. Also, there is a different type of the implant in this area. It depends on the bone and everything, and there is the area of the attached, the implant with the bone. This is the area it's going for the osseointegration going to be happen. And there is the classification of the dental implant. The first classification based on the implant design. There is the endosteal type, there is the subperiosteal type, and there is the transosteal type, intramucosal type. And the first one is the industrial type. There is the three types, subdivision of the industrial type. The ramus frame and the root form, and the last one is the blade form. We will go through these types as quick as we can. So the first one is the industrial implant. It's a device which is placed into the alveolar bone transect only on the cortical plate. Plate implant, thin plate in the form of the plate embedded into the bone, inside the bone. So we need high dense, or we need much space to put it inside because it's little big in the size. And the other type is the ramus frame implant, or it's horseshoe. It's horseshoe because it's a stainless steel device first, and then inserted into the mandible form in the retromolar bud area, go all around to the other retromolar bud area on the other side, and it's passed through the anterior area of the mandible. It's called the anterior symphyseal area. And the third type, it's root form an implant designed to mimic the shape of the tooth and for directional load distribution. There is the three type of this. It depends on the shape. There is the cylinder, the screw root form, and one combination between these two. Other one is the supraperiosteal, or it's epiperiosteal implant. It's placed directly beneath the periosteum, overlying the bone cortex. This is indicated in case with inadequate bone height. So there is some patient, they have inadequate height in the bone. In this case, we will go for this type of division of the implant. The deficiency of bone, it's going to be happen due early extraction, due to have the elderly patient, they have an resorption in their bone, they have any medical problem, and so on. The other type is the transductal implant, or its mandibular stable implant. Penetrate both the cortical plate, and it has the supraperiosteal and industrial component. So as we can see right on the screen here, there is a mandible jaw, and there is a lower bone on the mandible, and the red area, this is a gum, and there is the metal plate posed together, and there is the post on the top. Sorry. So the last one is intramucosal implant. So the intramucosal implant is inserted into the oral mucosa. It's used at the attached site for the metal insert of removable denture. So we will put the implant first and add the supporter, and then we can put the removable denture. There is the other type of classification depend on the macroscopic body design of the implant. The first one is a cylinder, serrated, plateau, perforated, salt, and hollow. Classification based on the surface of the tooth of the implant. There is the smooth, machined, texture, and coated. There is the different classification depends on different things. So based on the surgical time, also we have immediate post-extraction implant, and we have delay immediate post-extraction implant, and the late implant. So immediate implant, this is the implant is going to be happen after the extraction done. Delay immediate implant, this is depend on the situation of the patient. Sometimes we cannot put an implant at the same time. We need to give the patient another appointment to do the implant. Should be in 2 weeks to 3 months after extraction. And there's the other type, the late implant. It should be after 3 months of the extraction. So according to the time of the loading of the dental implant, there is immediate loading procedure, early loading, and delay. So the early one should be from 1 week to 12 weeks, and the other one, the delay, is going to be over than 3 months. So here we will go briefly about the implant component. So we have a 7 part of the implant. There is the body of the implant, the healing screw, the healing abutment, impression coping, and analog implant replica, the abutment, and the prosthetic crown. The first one is the body of the implant. As we can see in the picture here, the component that is placed with the bone during the first stage of the surgery. When we go after extraction, embed this implant inside the socket immediately. This is called the implant body. It could be threaded or non-threaded with or without hydroxyapatite coating. The second thing is the healing screw. The healing screw is the screw placed into the top of the implant surface to prevent a bone or soft tissue or debris from invading the abutment connection area during healing. So we don't need any tissue is going inside our implant during the procedure of the healing. That's why we need to cover the top of these with the screw. It facilitates the suturing of the soft tissue. The healing abutment is the temporary part. It's not a permanent one. This is the temporary part we place on the implant body to create canal through the mucosa while adjust the soft tissue healing and result in the pre-mucosal seal around the implant. So we need this hole at the end because we need to put a cosmetic or the prosthetic at the end of the implant before we put the final result. Also, this is called pre-mucosal extension or the gingival former. The impression cupping or the impression cap, it's used to transfer the position of the implant body or the abutment to the work cast. The dentist screw the impression cupping to the real impression body and then take an impression. The impression cupping reminds the fixed impression material and the lab analog added to the prior dispatch to the lab. So this is sharing between the lab technician and the dentist in the clinic. So this is the analog. This is the picture. It's showing like that. The analog are used by the lab technician to replicate the implant. We need to do another model for the implant. There's a position in the patient mouse. The other one we put it in the patient mouse. The model of the patient dentition is made using an impression. Here, this is in the lab. We put these all to fabricate it, the prosthetic. The analog provides a replica of the position of the implant from which technician can place and shape the abutment and build the crown. So there is the implant abutment. The implant abutment, this is intermediate connected. Should be connect between the implant body and the restoration. It may extend above the tissue. When we said restoration, that's mean the temporary restoration or should be the permanent restoration at the end. It's support or retainer prosthesis. It's the four type of the cylinder shoulders, angled and customized. There is a different type. Shoulder design provide the natural appearing emergence profile. Now I will go for the treatment. Just I want to ask if my colleague Muram, she's joined us or not, because she should continue from here. Muram? If she's not
I
here.
think she's not here, yeah.
She is not here. If she is not here, I can continue.
You can continue.
Okay, it's fine. So I will go for the treatment plan. So there is the clinical evaluation. The most important thing we have to go through the medical history. So after we finish the medical history, we can go for the condition of the alveolar bone. There is some patient example for the elderly patient doing extraction a long time ago. Sometimes we cannot do an implant for these patients. So the local evaluation of the site of the implant placement, alveolar bone, height, width, jaw relationship, and prosthetic restorability. Intraoral bone mapping, probe through the soft tissue axis, thickness of the soft tissue, and measuring the bone dimension at the proposed surgical site. Patient expectation, reasonable or not, the oral hygiene status. So there is the other thing is much important. We will go for the radiographic evaluation. We need to know the dents, the height, the width, and everything is going to be healthy before start the implant. So the type of the x-rays or the radiographic we needed is the 2D pre-apical occlusal panoramic lateral spirometric radiograph, 3D CT turn or CT scan apparatus computerized tomography, cone beam or CT or MRI. Study model analysis. To determine there is the clinical length of the prosthetic crown that will be supported by the implant, crown implant ratio. interarch distance, the implant axis. It should be parallel to the axis of the adjacent natural teeth. There is the number and size of the implant. So there is the surgical guides. When we need to put the implant, there is the surgical guides. We put it inside the patient mouth. After that, we can go through these hole and we can make a drill and we can create the hole for the implant. So these surgical guides, it's help the doctor to position the implant appropriately from the prosthetic point of the view. The holes drill into the acrylic to appropriate location with the proper axis orientation. So there is the stereography from the available CT data, and the model can be created from the solid block of the material by means of the computer-guided milling device. The advantage is precise evaluation of the actual osseous condition, surgical therapy, and helpful for the evaluation of the relationship of the mandible to maxilla. There is some factor affecting in the treatment. First of all, the implant position, number, size, design. Depend on the implant prosthesis design, implant support denture, overdenture, or fixed partial denture. Patient force factor, it's a parafunctional habit, masticatory forces, crown height, and occlusion. And the last thing is the bone density. So the bone evaluation, how we can evaluate the bone and when we can say we can do implant and when we can say we cannot do the implant. So it depends on the height of the bone, width of the bone, and length of the bone. So the bone height should be at least 10 millimeter. It's 10 to 12 millimeter in the posterior mandible because of the nerve proximity. And the bone width, the minimal width should be 6 to 7 millimeter, and the bone length, it should be 1.5 millimeter from the adjacent tooth and 3 millimeter from the adjacent implant. So from implant to implant, 3 millimeter, from the implant to the natural tooth would be 1.5. So 5 millimeter implant require at least 8 millimeter length of the bone. The bone angulation. Ideally, it's aligned with the force of the occlusion and it's parallel to the long axis prosthodontic restoration. So there is a specific angulation of each tooth to make the balance between the upper jaw and the lower jaw. If you go to the wrong angulation, it may affect the occlusion of the patient. It will lead to failure of the implant. So the premolar should be 10, the first molar 15 degrees, second molar 20 to 25 degrees. For the wider range should be safe, it's acceptable. So the implant size. There's in the mandible, the incisor and maxilla, so the upper jaw and the lower jaw should be the length 3 to 3.5. Maxillary anterior of the both arch and the mandibular canine should be 4 millimeter. For the all molar should be 5 to 6 millimeter. The minimum amount of the interocclusal space, that's the mean space between the upper and lower, it should be of 7 millimeters. Crown implant. The most ideal, the crown implant, 1 to 2. The more common is 1 to 1.5. The minimum required is 1 to 1. The crown implant increase the number of the implant, or the wider implant should be inserted on to counteract the increase in the stress. Bone density. For the softer bone, number and diameter of the implant must be increased with more and deeper thread. Bone density can be assessed by mixed classification is a bone density from the CT using in unit or in the CT number. He classified it into 4 groups from D1 to D4, and D5 is immature bone. So we have D1, D2, D3, and D4. So the higher the CT number dense in density, D1, there is the number. I don't think it's much important right now, but we can go for the shape of the classification. This is the D1 is dense cortical, it's anterior mandible, posterior mandible. The D2 is dense porous or cortical bone surrounding the dense trabecular bone. This is also should be the anterior mandible and the posterior mandible, sometimes in the maxilla. And the D3, this is the porous cortical bone surrounding the fine trabecular bone, anterior and posterior maxilla. And the last one is D4, is the fine trabecular bone, is the posterior maxilla only. So that's mean this one is the less density. The surgical procedure. Surgical can be done in one stage or two stage. Two-stage surgery. In the first stage, implant at the surgical place under the gum, and the patient is made to wait for 6 months osseointegration. The second stage surgery is then performed where the healing gingival former is placed on after a week and satisfactory formation of the gingival collar for the emergent profile achieved. Impressions are made for the implant prosthesis, which may be cemented to or screw retained. One-stage surgery, implant is placed and left exposed to the gum. In this case, second-stage surgery is not needed. So there is a preoperative care. The preoperative care, the surgical site preparation and isolation, preoperative antibiotic prophylaxis, oral dose of 2 grams penicillin before 1 hour, and local anesthesia. Incision, mid-crystal incision with the margin of 1.5 keratinized tissue buccal extended to the occlusal adjacent teeth, and the flap should be reflected and elevated. The implant osteotomy, after the bone is exposed, after we did the surgical exposed the bone, the surgical guide template, its position is direct to angulation of the implant. There is a specific speed we need to use, 1,500 to 2,000. It is a high torque, and beats and copious irrigation are necessary to prevent excess thermal injury to the bone or excess heating. So this is the machine we need to do for the implant, and this is the hand piece, and this is the burr. We should drill the bone with this tip of the burr. Keep the local bone temperature at the normal body temperature, and also the flush out the bone debris from the drilled hole. A normal saline at the room temperature is ideal. There is the various type of physiodispenser are available, which can control speed, torque, and irrigation. This is type, and this is the other type. And this is the type of the burr. It depends on the size, anterior teeth, and the premolar and the molar area. The manufacturer give a guide to the squeeze, the drill size to be used in order to make proper size drill hole for a particular implant. The drill are marked for a depth to guide the surgeon. Drill are used in ascending order of diameter. Recommended drill speed is 800. With the initial drill, the central of the implant recipient site is marked, and the initial pilot hole is the prepared purling pin is the place initial preparation to check alignment and angulation. If it is appropriate, the drill hole sequentially enlarge the dimension of the implant. After desired the depth of the diameter of the recipient site complete, the implant can be placed immediately. The implant placement. After the final osteotomy, the site is leave and aspirated to remove debris and blood. Everything is clean. We put the hole and everything. For the titanium implant, uncontaminated surface oxide layer is necessary to obtain osseointegration. So touching with gloves, soft tissue, or dissimilar metal should be avoided. The implant is rotated with 3 grams by the low speed, high torque, and the hand piece retracted. It should be rigid with no mobility on slight compression. Post-insertion radiographs evaluate the position, adjustment, the vital structure. We need to do, it's most important to do an X-ray after insert or position the implant immediately to make sure we are in the good position. Try to avoid any injury or of the nerve. Cover screw is inserted, the flap are sutured. If an implant position is not corrected, it may be removed and reinserted after several months later. We cannot do it at the same time. The second stage surgery. In the second stage surgery is preferable shape. Incision is made in the overlying mucosa and the cover screw is exposed and removed with a hex driver. This is one of the type of the drill, and it's replaced with the gingival former and it's left for 7 to 17 days. The gingival former help formation of the gingival collar around the future abutment with help in gingiva, the final prosthesis, a more natural appearance. Prosthetic face impression. After the healing period, gingival former is removed the impression copying and put onto the implant, and the impression is taken by open-close technique. There is a specific technique. We need to take an impression to send it to the lab. The implant and the logit is affixed on the impression copying to the impression to pour in dye stone. This is procedure also. It's happened in the lab. Now the unlocked is seated die with the same angulation and in the bone. On the plaster is the set copying to remove and abutment are placed over the lab analogues. Then the crown is fabricated over the abutment. When we receive the crown, we can just cement it directly. After the fabricate of the prosthesis, the abutment is taken off the cast, leaving the implant and loaded in the cast. This is abutment cast. Now be transferred and screw into the implant and prosthetic fixed to it. So the occlusal adjustment are undertaken is required. After we put the prosthesis or the teeth or the molar, we receive it from the lab. The most important thing we need to check the occlusion, the bite of the patient should be everything is normal. The complication. So the complication, there is intraoperative flap tear may be happen during the surgical procedure. Insufficient irrigation may lead to some nerve injury or damage to the tissue, more damage to the tissue, perforation of the buccal or the lingual cortex, inferior alveolar nerve injury, implant drill of the adjacent tooth root. It can be happen sometimes. Perforation of the maxillary sinus, perforation of the from fossa base, lack of the primary stability of the implant, fracture of the implant. Immediate post-operative is swelling, nerve injury, pain, hemorrhage, and the delay is going to be infection, secondary hemorrhage, nerve injury, looseness of the implant, and the implant exposure. Implant failure, there is the mobility of the implant during healing period. There is some degree of the mobility is going to be happen, but there is some mobility is not acceptable, so that means the implant immediately is failed. Pain, infection, radiolucency around the implant, whatever the cause, the implant should be removed. Grafting and reinsertion can be done after 8 to 10 weeks. Complementary procedure, bone grafting for the implant done when the bone is too narrow or too short to place on a adequate side of the implant. Sinus lift, our sinus are located close proximity to the upper posterior jaw bone. In the same case, if the sinus front dips down, causing the area to lose bone height, then the sinus lift procedure is necessary in order to increase the bone height. A cortical window 2 to 3 millimeters above the sinus floor is created with a round burr down to the membrane of the sinus. Careful in fracture of the window within this dissection of the sinus membrane of the sinus floor create the space necessary for the graft placement. The corticocancellous plaques may be placed into the resulting defect. This is the window and this is the shape. This is the position of the handpiece should be like this. So the conclusion, dental implants have overall had a high success rate, but their placement and restoration still have the boundaries of the biomedical science and art. The effectiveness of different design of implants support prosthesis as well as associated treatment modalities lead to improvement in speech, function, and quality of life. Thank you so much. I'm so sorry. I'm going to fast a little bit because I know the topic is it's too much a slide, but I hope I cover everything as it is. And thank you so much for my team leader support, and thank you for you, Dr. Nader. If you have any question, anything, I'm here. Thank you.
Thank you so much. This is great and excellent. It's an important topic. Thank you so much for the great presentation.
Thank you so much, Wala. Could you please make me the host again so that I can share my slide?
Okay, I will. I think now you can share your screen, right?
Okay. No, I can't. Can you go to the participant and on my name, you can make me the host?
Okay.
Thank you.
You're welcome.
Great. Hi, everyone. So I'm sharing my screen now. Yeah. Can you guys see my screen?
Yes.
Okay.
Yes.
Thank you, Wala, and thank you, Dr. Nadir, for this opportunity. The topic today I'm presenting is neuropsychiatric issues after stroke, clinical significance and therapeutic implications. My name is Dr. Marina Das, and this is a journal which was presented by to Journal of World Journal of Psychiatry by So Zhang et al. So to begin with, I chose this topic because while rotations in my neurology department, outpatient, I saw a patient who came after a stroke follow-up. He already had hemiplegia and he was in the rehabilitation procedure. But when I saw him, he was like very jolly, very happy. He was laughing incessantly while his wife was very grim and sad. So before I could understand what was happening, after this history and discussion, I came to know about the psychiatric issues which take place after stroke, that he was undergoing a pseudobulbar effect and emotional lability, which creates a disorder where the person either excessively cries or laughs, and this has social implications. So that got me interested into this topic, and so here I'm presenting you today about it. So to begin with, a little background of stroke. Stroke has become the second leading cause of death for people over age of 60, and fifth leading cause in the people between ages of 15 and 59 worldwide. So there are psychiatric disorders that are very common after stroke and traumatic brain injury, both in short term and long term. The psychiatric disorders that are more common after a stroke are mainly depression and anxiety. And these are associated with worsened outcomes, including low quality of life and increasing the burden of the caregiver and unfavorable functional status. The purpose of this paper was to summarize the research advances of neuropsychiatric disorders developing post-stroke, focusing mainly on clinical significance and therapeutic strategies. The opinions on management and treatment mainly depend on the results from studies of evidence-based medicine. So these psychiatric manifestations post-stroke, mainly maximum of them are post-stroke depression and anxiety disorders. Apart from them, people present with emotional lability, post-traumatic stress disorder, psychosis, and very important are drug interactions, which we will learn in the following slides. So the risk factors for neuropsychiatric disorders after stroke, the risk factors mainly enumerate a few factors. Mainly, I would say the family history of psychiatric disorders. A meta-analysis showed that the stroke patients with family history of psychiatric disorders have an increased risk for developing post-stroke depression. In addition to that, serotonin transporter gene is a common gene associated with depression. And a meta-analysis of 4 studies with 641 individuals indicated that there was a positive association between the homozygous short variation allele genotype of the serotonin transporter linked promoter region and post-stroke depression, whereas the homozygous long variation had a significant negative association. Apart from that, post-stroke patients with brain-derived neurotrophic factor gene hypermethylation levels and brain-derived neurotrophic factor gene polymorphisms had a higher risk of developing post-stroke depression and post-stroke anxiety. Polymorphism in the tryptophan hydroxylase 2 gene was also found to be involved in post-stroke anxiety susceptibility. A meta-analysis published in 2017 with 36 studies showed that the correlation between history of psychiatric disorders and post-stroke depression was the highest among all the factors. So coming to post-stroke depressive disorders. So in this, as I earlier said, that this is the most common form of psychiatric disorder after stroke. A prospective study showed PSD can occur from 1 to 18 months after stroke onset, and the prevalence of depression was not found to vary considerably over time. So this was also compared with orthopedic patients with similar degrees of motor disability, myocardial infarction, and similar predisposing factors of cardiovascular diseases. Patients with stroke are more likely to suffer from repressive disorders, which suggested that there is a more complex neurobiological mechanism for the etiology of post-stroke depressive disorder. A previous meta-analysis of 61 studies also showed that the frequency of post-stroke depression was 34%. Generally, this depression occurs in a range of 25 to 35% of stroke survivors, with the frequency estimated to be the highest in the first year after onset, after which it gradually declines. So how do we screen post-stroke depression? So there are various methods for it. Optimal screening for the identification of PSD is vital for the following treatment and management. However, there is no established diagnostic criterion. The DSM-5 classifies this post-stroke depression as a depressive disorder due to another medical condition. This identification and diagnosis of PSD is usually based on the combination of detailed clinical assessment and screening scale tools in clinical practice. So the various scales that have been used are Center for Epidemiology Studies Depression Scale, Hospital Anxiety Depression Scale, Hamilton Depression Scale, and Beck Depression Inventory, Geriatric Depression Scale, and 9-item Patient Health Questionnaire. However, PHQ-9 is the most commonly used tool for screening of PSD. It has high validity and high reliability. So this post-stroke depression is associated with worsened functional outcomes after stroke. There was a meta-analysis done where with 14 studies which revealed that PSD showed a negative impact on survival rates. And SSRIs and antithrombotics are always simultaneously prescribed for patients with PSD in clinical practice. Clopidogrel is one of the most commonly used antiplatelet medications that prevent and treat ischemic stroke. However, there is significant interaction of clopidogrel with these SSRIs like fluoxetine and fluoxamine, which can decrease the therapeutic efficacy of clopidogrel by cytochrome inhibition. So patients using clopidogrel who were co-prescribed these fluoxetine and fluoxamine had 11% higher risk of developing ischemic disease than patients using clopidogrel who were treated with non-inhibiting SSRIs. So fluoxetine, fluoxamine, and paroxetine are reported to have potential interactions with warfarin and inhibit warfarin metabolism by competitively binding the plasma protein and interfering with CFYP isoenzymes, which are more likely to strengthen the anticoagulant effects of warfarin. So we have to be careful when we prescribe these drugs. Another important therapeutic measure could be CBT, and CBT, chronic behavioral therapy, may be the most effective psychotherapeutic intervention, but it is not well established. SSRI should not be prescribed prophylactically in all post-stroke patients. Rather, they should be screened for depression. And if they are diagnosed, then only we can use SSRIs or SNRIs with some sort of help with psychological intervention. So both neurologists and psychiatrists need to be aware of this drug and drug interaction, which can be potentially life-threatening. So, and tailor these treatment modalities according to the need of the patient. Coming to post-stroke anxiety disorders, these are relatively common, next in line to post-stroke depression, and screening and identification can be done by using
It seems Dr. Das, Marina Das has a little bit of. She's back. We'll give her a couple of seconds and see if she can join again.
Sorry, Dr. Nadir, there was some issue with the internet and I got disconnected.
That's okay. So are you able to share the screen now?
Give me one moment. I'll try to share it from my from the app.
Okay, sounds good.
Okay. And Dr. Nadir, I'm unable to find that upcoming presentation tab from which I can share the slide. Could you help me with that?
Sure, give me a second.
Dr. Nader, if you want, we can go ahead with the poster presentation and give time for the technical problems to be solved. If you want, that's an option.
Yeah, you can go ahead. I can resume it later. I think it is just taking some time. I'm really sorry.
Don't worry.
Yeah, okay.
No, of course not. We're here to help each other.
Sure, you can do that. So I'll give you the host so you can.
Dr. Nader, okay. Mayra, can you share your screen or do you want me to share it?
If you can share yours, because mine is
okay. Dr. Nader, would it be okay to put me as the host and I will share my screen?
Yes, done.
Okay, thank you. Can everyone see my screen?
Yes, we see it. Thank you, Nan.
Okay. You're welcome. Go ahead, Mayra.
Okay, perfect. Well, good afternoon, everybody. My name is Mayra, and we are here to present our poster presentation that is going to be on July, and it's about confabulation of fluctuating memory, a case of Alzheimer's dementia in a culturally diverse patient. The participants and the fellows in these poster presentations are Dr. Nidhal, Dr. Nidhal, myself, Mayra Messoni, and Dr. Nadir Aldarihan. I'm gonna do the introduction for you guys and objectives, and then Dr. Nera is gonna do the case, and Dr. Nidhal, she's gonna do the results and conclusions. For the introduction, confabulation is the fabrication of details with short lucid intervals, hinders the diagnosis of Alzheimer's and other dementias. This case report explores the complexities and diagnosing and management Alzheimer's dementia in a culturally diverse patient, exhibiting fluctuating memory and confabulation, emphasizing challenges highlighted by the cultural and linguistic factors. In the objective of this case, we want to understand the significance of culturally sensitive approach in cognitive assessment and holistic care, and the recognized importance of reorientation, redirection, and storytelling as a techniques for managing patients with Alzheimer's dementia. Now is Dr. Nera's turn in explaining the case.
Thank you. And regarding the case, it's an 84-year-old man of African descent, born and raised in Africa. He has recently relocated to the US. He's independent in basic daily activities, but struggles with instrumental tasks. So confabulation in this trilingual patient who spoke English, German, and Arabic was posing a challenge regarding the assessment. So this challenge necessitated a closer look at his cultural background, language barriers, and family dynamics. So regarding the assessment and diagnosis of this patient, the evaluation was done by the MOCA score, the Montreal Cognitive Assessment. He scored 12 out of 30, which indicates a moderate cognitive impairment. During the evaluation, it was important to consider the language nuances and cultural influences. For the labs, a slightly low vitamin B12 level was found, but otherwise was unremarkable. Regarding the management in this patient, family education was crucial, and the family was educated regarding the use of storytelling. The treatment approaches was first, we had the non-pharmacological, which is reorientation, redirection, and storytelling mainly. And then we had the medication. The patient was started on oral vitamin B12 daily. Regarding the donepezil, it was prescribed but not initiated in this patient due to side effect concerns, and the melatonin was used as needed for sleep disturbances. So this is regarding the case. Now we're going to the results with Dr. Nidhal.
Regarding the results, family involvement played a pivotal role in holistic care coordination. Also, in the non-pharmacological approaches such as reorientation, redirection, as well as storytelling were effective. In conclusion, this case highlights the importance of, firstly, culturally sensitive cognitive assessment to address language barriers and cultural nuances. Secondly, is collaboration with family members for comprehensive care. And finally, continued research on Alzheimer's presentation in diverse population is necessary. Thank you very much. I hope you enjoyed our presentation. If you have any question, please feel free to ask.
Thank you, guys.
Okay, so if anyone has any comment regarding the poster, it would be very helpful if you could let us know. And if you have any questions as well, we are happy to answer it.
Excellent, excellent presentation. So I think you did it in the time required. So all of you,
We're trying.
We timed ourselves.
We try to time ourselves.
Yeah.
We're trying.
Thank you so
trying,
much. It
Dr.
was
Nadi, because for me, it's so hard to pronounce the name of my friends, and I practice it so much.
So this is how we did it in the past. So this poster will be presented at the Alzheimer Association conference, and this will be in July. It's an annual conference, and it's international conference. Sometimes it's in the US, sometimes in other countries, Holland or Germany sometimes. So congratulations, this is great work. So for the other fellows, if you have any comments or any suggestions, any notes about the presentation, please raise your hand or jump and give us your feedback.
Thank you.
Positive or any area for improvement.
Thank you, Dr. Nader. If you have any comments, Dr. Nader, it would be much appreciated as well.
I think you did great, and I like the idea that everyone will introduce the name and then go ahead with the part there at the task that they will present. I think what we're gonna do is we're gonna ask you to do your part as a video, small video short. So we'll add that video on the top, on the left upper corner, the logo. On the top right corner will be your video. When you are talking, it will appear. And as soon as you finish, the second person will be there. So the
like last year, we saw that last year that the person was there.
So it will be the three videos from the three of you guys. So
perfect.
That sounds good.
We're gonna try to do it with the Canva tool that you gave us.
Exactly. And we were gonna try and put our names downwards, like next to our videos, so it wouldn't take much time actually. Yeah, exactly. Introducing ourselves.
That's a good idea. That's excellent.
When is your presentation, Nada, Dr. Nada?
You want to see it? Yeah, sure.
When is your presentation dated?
When? It's like the conference is at the end of July, 1st of August. So we still don't have the date itself, but it should be within that time.
Okay, great. Congratulations for acceptance. Yeah.
Thank you so much. Thank you.
Yeah, and good luck.
Thank you.
Right. So we can move on to the topic. And Marina, did you get the...
Yeah, I could actually. Yeah.
Complete.
No problem. Yeah.
Thank you so much, all of you, the three of you, Mayra, and Nidhal. Thanks.
Thank you, Dr. Nader. Thank you.
Thank you
so much.
So, yeah, Dr. Nader, could you?
Now you are in the house. Go ahead.
Okay, thank you. Okay. I believe you guys can see my screen. Sorry for the interruption earlier. Resuming post-stroke anxiety disorders. The management is there are no widely accepted guidelines. However, several classes of pharmacotherapy were used to treat post-stroke anxiety, including SSRIs, tricyclic antidepressants, and benzodiazepines. There is also conflicting conclusions to a meta-analysis and a Cochrane review, which suggests that there was no high-quality clinical evidence to guide this management of anxiety. However, a systematic review revealed that interventions like yoga, tai chi, mind-body interventions have been potentially beneficial for treating both post-stroke anxiety and post-stroke depression by improving the mood and quality of life of stroke survivors. So, PTSD after stroke, post-traumatic disorder is a mental health condition that develops following a traumatic event, including acute stroke and transient ischemic attack. Under DSM-5, PTSD is categorized as a subtype of anxiety disorder with post-stroke prevalence of 8 to 29. The symptoms, as we know, is intrusive memories, alterations in physical reactions and arousal, avoidance, negative alterations in cognition and mood. And these patients mostly coexist with post-stroke depression and post-stroke anxiety. So there was a cross-sectional study done where the post-stroke PTSD were co-occurred with PSD and post-stroke anxiety disorders. So approximately 40% patients with NDS comorbidity have above 3 psychiatric disorders. So a variety of assessment scales were used for screening. So PTSD checklist for a stressor, TIA or stroke as a stressor, clinician administered PTSD scale, or structured clinical interview for DSM. So management is, there is no high quality randomized controlled trial evaluating the efficacy of pharmacotherapy or psychotherapy. However, some of the interventions could be tried, like the usual antidepressants and anxiolytic sympathetic inhibitors or antipsychotics. And sedative drugs can also be tried. But CBT, trauma-focused psychotherapies and exposure therapies are very useful for facilitating compliance for developing strategies. So these can be used. Coming to psychotic disorders after stroke. So psychosis may manifest within 1 week after stroke and rapidly develop into psychotic disorders. But psychosis would also be delayed and can also occur several weeks after the onset. So delusions and hallucinations may be permanent as an accompanying sequel or temporary, resulting in functional rehabilitation. It has a prevalence of 4 to 5%. And the most prominent symptoms of psychosis included delusions, hallucinations, which can be accompanied by disorganized speech, catatonia, inappropriate motor behavior, typically followed by acute severe stroke. So as these are not very fairly studied, so there is no acknowledged diagnostic criterion. However, the DSM criteria are generally used. So neuropsychiatric inventory was administered to stroke survivors for detecting delusions and hallucinations in some studies. The management is there is no randomized controlled trial study, not much evidence is there. However, some case reports and case series studies have stroke survivors with psychosis or psychotic disorders who were mostly treated with antipsychotic medication. So approximately 2/3 of those patients attained complete or partial recovery. Second generation antipsychotic drugs like risperidone, quetiapine, and olanzapine were the most commonly used antipsychotic medication for stroke psychosis. But the safety of these antipsychotics for patients was a bit controversial. So there was a meta-analysis done which suggested that olanzapine and clozapine showed the most unfavorable effects on metabolism. So previous studies have concluded that either first or second generation antipsychotic drugs may increase the risk of stroke, especially for people with vascular dementia. So safer alternative could be CBT or physical neuromodulation or psychosocial therapy. These are promising therapeutic options. As a conclusion, psychiatric disorders following stroke present unique challenges for the treating psychiatrist or neurologist. There is still a lack of widely acknowledged structural scale for screening and assessing each neuropsychiatric disorder. Pharmacotherapy by modulating neurotransmitters is the main treatment of modality of NDS. Except for depression being studied extensively, large-scale randomized double-blind control trials are still required to determine the efficacy of pharmaceuticals and psychological therapies for NDS. So further aim should attempt to develop protocols or guidelines for treatment and diagnosis or prevention of neuropsychotic disorders after stroke. So for emotional lability, there is a drug. There are some few case reports with using quinidine and dextromethorphan. They have also been used for patients with emotional lability with multiple sclerosis. But however, no studies have been done so far specifically for stroke survivors. So there is a chance of more research and more studies done here. So that is my presentation today. Thank you for your patience and sorry for the interruption again.
Thank you so much, Dr. Marina, for this excellent presentation. So what happened is Dr. Marina found this article and she's interested in doing some work in this area. So she asked me if she can present that. And this can be for any one of you to help us share the knowledge or the skills or any area that we can help each other with. So the agenda for each meeting will have some room for any of you to share their expertise or their skills or knowledge so that others can benefit. So it's a teaching moment for all of you. Excellent, Marina. The only thing I want is we can double the benefit out of it. So she will benefit from teaching us and will know the topic. But if we can convert this into another item, for example, can we get an idea, research idea of this topic? Can we make a systematic review in this regard, or we can modify the topic to certain area? So think about it, Marina, and you can come up.
Yeah, I was thinking about it. Yeah, but there is very minimal research on it. Even reviews are very less. Those present are very old articles. A recent article has been is in 2022. Not many clinical trials have been done. So yeah, there is scope of research. That's what I think. Yeah.
Yes. So you can come up with some ideas, create your team, and then some of the fellows who are.
Sure. Thank you.
Thank you.
If you guys have any questions, you can ask, or I can move on to the next presenter.
You can move on.
Yeah. Dr. Mellad, are you there?
Yeah, I am here. Please make me the host.
Yeah, I'm making you the host. You can start sharing.
Okay.
Okay. Thank you. You can start.
Hello, everybody. Could you see my screen?
Yes.
Yes, we do.
Yes. First of all, I wanted to say thank you, Dr. Nader, and thank you, everybody, for this opportunity. I am Dr. Milad Sayah from Cairo University. I want to our topic today will be about systematic review and meta-analysis, the importance of systematic review, and how to the important items that we report when we do systematic review. First of all, we know that systematic review is in the top of the triangle of evidence, and it is the most rare. And we use it to develop guidelines, so that it's very important, and it's very important that it be when we report its item, it be very accurate. Is there any other type of reviews? Yes, there is a narrative review, and there is a systematic review meta-analysis that we are talking about today. About the narrative review, it provides an overview on a particular topic. So it's an overview, not focused. Often cover a wide range of issues within a given topic. Can be useful for understanding new concepts. What is the drawbacks of narrative review? They are rarely comprehensive. They don't reveal many details about their methodology. They are highly susceptible to reviewer bias. They seldom take into account the difference in the quality of studies it includes. They can often come to the wrong conclusion, so careful interpretation of the result should be done. This is an example of the narrative review, as we see in the abstract underneath. Like he say, we did that, and it is an overview of the result. So it is not focused like systematic review. On the other hand, systematic review is a scientific investigation that focuses on a specific question and use explicit and pre-specified scientific methods to identify, select, assess, and summarize the finding of similar but separate studies. It may include quantitative synthesis and that what we call the meta-analysis, depending on the available data. The importance of systematic review, it is used to develop the clinical guideline, also policy decisions. But the quality of published systematic review is variable and often inadequate. This slide is from 2012, so they did a study in 2009, and we will see the result later. In many cases, we are unable to judge the quality of systematic review because the methodology is poorly reported or the systematic review is poorly conducted. This is the characteristic of a systematic review. It should be focused, well-defined research question, what we call BICOS, clearly stated title and objective. A comprehensive strategy for identification of all relevant study that published or not yet published, explicit and justified, predefined inclusions and exclusion criteria. We should do critical appraisal of the original study. We will include clear analysis of the result of eligible studies. We do quantitative, like meta-analysis if it is available, or qualitative. And the structured report. The structured report, we have two methods, the Cochrane method and the PRISMA method that we will talk about today. So the Cochrane method is a systematic review coordinated by Cochrane collaboration. Cochrane collaboration, established in 1993, they are a group of researchers. It's a non-profit, around 28,000 researchers from 100 countries, and the systematic review published about 4,600. They are internationally recognized as the benchmark and the gold standard for high quality information about the effectiveness of healthcare. The systematic review, Cochrane systematic review, published in Cochrane Library. And it is also published by Wiley-Blackwell and indexed in the PubMed with impact factor 6.1. And it has free access in many countries like UK and other countries. So we will talk about the methodology because this is the most important part in systematic review. Methodology of Cochrane review, a methodology robustly developed continuous improvement. There is a handbook, free online access. That it's a book in the Cochrane website. We can see it discusses how we do the methodology and the items reported. And there is a course also in the Cochrane training. If anybody wanted to join it, like I am from Egypt, it's free for people from Egypt and from other countries, and it is reduced for some other countries, reduce the price. Processes of conducting Cochrane systematic review. First of all, the protocol. It minimizes the potential bias in the review conduct. Review are retrospective, like we develop the protocol first and we know what will we do before we conduct the study. Need to establish the methods in advance. Planning, review team. Cochrane protocols are peer reviewed and published. So we can see the protocol of each systematic review of the Cochrane systematic review. Cochrane review conduct, first the protocol, second the objective. The objective must be focused, well-defined research question, what we call BICOS, and there should be a primary outcome only. Minimum number of secondary outcomes include adverse event harms if relevant. The literature search should be comprehensive. We at least one database, electronic databases. Also the gray literature. Gray literature is like that not have a commercial publisher, like the governmental website, the census, and like any papers, like governmental papers, this stuff. Reference lists, personal communication. Useful to involve an information specialist in developing search strategies. Consider SS peer review. I don't know SS is abbreviation for. I searched for it, but I didn't find. I think statistical, maybe. If Dr. Nader know, like, can help us with this SS peer review.
I'll try to find it out.
Okay, thank you, Dr. Nidhal. So keep detailed record of search method and the search result. When we report the study, we should keep record of search methods and search results. Data collection and analysis, selection of studies using, as we said, predefined. We defined it in the protocol, selection criteria, independently done by more than one reviewer. So systematic review can't be done with one author. It should be at two, because the selection of a study, predefined selection criteria should be done by two separate authors included in the study. Important to determine how to solve disagreement between reviewers. The data extraction form, like pilot items format. Pilot is like a study we conduct before the main study on a small group. We see the feasibility of a study and if is there any harm and if it can be done or not. Independently done by more than one reviewer. Also, the data extraction should include two authors. Assessment of risk of bias. Problem with the design and executive of individual studies of healthcare. Intervention raise questions about the validity of their findings. In clinical trials, bias can be broadly categorized as selection bias, performance bias, detection, attrition, reporting, and other biases that don't fit into these categories. Cochrane collaboration developed the risk of bias tool, 7 specific domain, the sequence generation, selection bias, allocation concealment, selection bias also, blinding of participant and personnel, performance bias, blinding of outcome assessment, detection bias, and incomplete outcome data, attrition bias, selective outcome reporting bias, other potential source of bias. The data synthesis can be qualitative, descriptive summary, or if it's available data, we can work statistics on it, so it will be quantitative, the meta-analysis. It pull data from multiple study that, as we said, it's separate but similar. Minimal differences between studies, outcome measured in the same way, the outcome, data are available. Interpretation of results, clear statement of findings, author conclusion should reflect findings, clear presentation is important, summary of findings, tables, because tables are quick and accessible format, relating the quality of evidence to the outcome. The Cochrane systematic review, what is the difference between the Cochrane systematic review and the other systematic review published in other journals? In the shape or the structure of the systematic review, like Cochrane has some specific rules, e.g. title structure. A title can't start with a or the, and should not include systematic review of. Publishing in other journal, we follow PRISMA statement. Referred reporting items for systematic review. That's PRISMA abbreviation for is the preferred reporting items for systematic reviews and meta-analyses. 27 items checklist, flow diagram. PRISMA authors are also heavily involved in the Cochrane work, so the two methods are highly compatible and reliable to each other. Why it is important to report systematic review very accurate? Because poor reporting of the original paper included in systematic review can will bring wrong conclusion, and we depend on systematic review for guidelines. So reviews are not immune to the problems of poor reporting. This is a study done with Moore et al. in PLOS Medicine in 2007, and they included 300 systematic reviews, of which 125 were Cochrane reviews. The overall quality of reporting of key aspect of methodology was very inconsistent, with particularly discouraging findings for non-Cochrane reviews. That's why in 2009 the PRISMA come to the light, and the PRISMA, as we said, it's a 27 checklist, including first the title, and the title here identify the report as systematic review. In Cochrane we should not say systematic review, but in PRISMA we should say systematic review and the meta-analysis, or both. The abstract should be structured, provide a structured summary, including as applicable background, objective, data sources, study eligibility criteria, participant and interventions, study appraisal, synthesis method, results, limitation, conclusion, and implication of key finding, systematic review, registration number. After the abstract, the introduction include rationale, describe the rationale for the review in the context of what is already known. Objective, provide an explicit statement of question being addressed with reference to participant, intervention, comparison, outcome, and study design BICOS. Methods, protocol and registration. We complete the methods. Protocol and registration indicate if a review protocol exists, if and where it can be accessed. Like we said, Cochrane, all Cochrane systematic reviews have protocol, and if this systematic review have protocol where it can be accessed, web address, and if available, provide the registration information, including registration number. Eligibility criteria, specify study characteristics. The study we include in the systematic review, we should give its characteristics. BICOS and the length of follow-up and the report characteristics, years considered, language, publication status, used as criteria for eligibility, and giving rationale. Information sources, describe all information sources, the databases with dates of coverage, contact with study authors, to identify additional studies in the search and the data last searched. Date last searched. Search, present full electronic search strategy for at least one database, including any limits used such that it could be repeated. Study selection, state the process for selecting studies, screening eligibility, including in systematic review, and if applicable, including in the meta-analysis. Data collection process, describe a method of data extraction from reports, e.g. pilot forms, independently, in duplicate, and any process for obtaining and confirming data from investigators. Data items list and define all variables for which data were sought and searched for, e.g. BICOS, funding sources, and any assumption and simplifications made. We continue the methods. A risk of bias in individual studies. Each study we included in the systematic review, we should describe the method used for assessing the risk of bias in this study, including specification of whether this was done at the study or the outcome level, and how this information is to be used in any data synthesis. Summary measures state the principal summary measures, e.g. The risk ratio or difference in means. Synthesis of result, describe the methods of handling data and combining result of studies if done, including measures of consistency, e.g. I square or I2 for each meta-analysis. The I2 is the estimate of the proportion of variability that's due to difference between the study included, not due to sampling error. Like this is the estimate. It is a true difference because of difference in study concluded, not due to sampling error. Risk of bias across studies. Specify an assessment of risk of bias that may affect the cumulative evidence, e.g. publication bias, selective reporting within studies. Additional analysis, if there is additional analysis, we should describe the methods of additional analysis, sensitivity or subgroup analysis, meta-regression if done, indicating which were pre-specified. I only have 2 minutes. So the result, study selection, give number of studies screened, assessed for eligibility, and include in the review with reasons for exclusion at each stage, ideally with a flow diagram. Study characteristics. For each study, present characteristics for which data were extracted, study size, PICOS, follow-up period, and provide the citation. Risk of bias. Present data on risk of bias each study and if available any outcome level assessment. Results of individual studies. For all outcome consider benefit or harm present for each study. Simple summary data for each intervention group. Effect estimate and the confidence interval, ideally with a forest plot. Synthesis of result. Present result of each meta-analysis done, including confidence interval and measures of consistency. Risk of bias across studies. Present result of any assessment of risk of bias across studies. Additional analysis. Give the results of additional analysis of done, sensitivity or subgroup analysis, meta-regression. So item 21, we should say like we present the main result of the review. If meta-analysis are done, include for each confidence interval and the measure of consistency. Summary of evidence summarizes the main finding, including strengths of evidence of each mean outcome. Consider the relevancy to the key group, healthcare providers, users, and policymakers. Limitations. Discuss the limitation at study and outcome level, risk of bias, and at review level, incomplete retrieval of identified research reporting bias. The conclusion. Provide the general interpretation of the result in the context of other evidence and implicate for further research. The funding. Describe the funding resource for the systematic review and other support supply of data. Role of funders for the systematic review. This is a diagram. We first do identify the study and if there is additional records, as we said, published or not published, not yet published. And we record after duplicate remove, record screened. We already predefined exclusion criteria, so we can exclude some studies. Full text article assessed for eligibility. Some might be excluded. The studies included in qualitative synthesis. The studies included in quantitative synthesis meta-analysis. This is the updated PRISMA 2020. It's the same as the 2009, but updated in the terms, and they added some items for it. It is on the PRISMA website. We can read it. PRISMA explanation and elaboration paper. This also on the PRISMA website. Explanation and rationale for reporting of suggested information items. Why we report each item in the systematic review. Examples of good reporting. Relevant data about how this information is reported presently. It might be long and take time to read, but this will help us to avoid basic mistake in systematic review reports. This is the website of PRISMA, and this is the Equator who invented this slide, equatornetwork.org. Thank you, everybody. We reach the end of our presentation. I wish I could like give you some overview about systematic review.
Thank you. It was a good presentation. Well done.
Thank you.
Thank you so much, Dr. Milad. This is an excellent presentation and it's an important topic.
Thank you, Dr. Nader.
Any questions or any comments or addition? If not, we can move on to next item in the agenda.
Yeah, we are done with the presenters, Dr. Nader, and
So we'll go to the
updates. Yeah.
Any updates as far as new projects that are going on, or new ideas, any suggestions?
Assalamu alaikum, Dr. Nader. How are you?
Rahman, very good. How are you, Dr. Ryan?
Alhamdulillah. I do have an update. Our research titled The Impact of COVID-19 on Precocious Puberty was accepted by the American Academy of Pediatrics, alhamdulillah. So we have that presentation coming up in September.
Excellent. Congratulations.
Thank you so much. You know, me and my team worked hard, so quite happy about that.
Very good. Excellent. So you're going to start working on the poster and next.
Yeah, that's correct. I'm going to start working on the poster, and I believe they also have a journal, so it's also inshallah going to be published. But we're also going to look at finishing off the manuscript as well, inshallah.
Inshallah. Excellent. Congratulations.
Thank you so much.
Good work. Thanks for
Thank
sharing.
you. Of course. Thank you, Dr. Nader, for your continuous support.
Thanks. Anyone else with any updates or ideas, any suggestions?
I do have one update as well, sorry. So my team and I are also working on a manuscript. It's on the cognitive effects imposed on PCOS, so polycystic ovarian syndrome. Alhamdulillah, we finished extraction. We're almost done quality assessment right now. So hopefully by the end of next week, we want to publish the manuscript in Curious, inshallah. And we were actually able to have a PGY2 resident in New York join our team. So it was a really good support, and he helped guide us as well with like his experience on manuscripts. So alhamdulillah, that project is going well, and hopefully we'll be done within the next week.
Excellent. Congratulations. That's good also. So you are moving good.
No, it's good.
If we can also start collaborating with other either residents or fellows in other programs, that will help us with connections and will help on population. So yeah,
for sure. I've done like many abstracts, but this will be my first like completed manuscript, so looking forward to that for sure. Again, I have a great team, alhamdulillah, so I can only give my thanks to them.
Excellent. If I may, how did you come across the resident, and how did that collaboration start?
So one of my colleagues, actually, it was connected through LinkedIn. So just through the different networks and different connections, there was an interest there. And then we had a meeting with the rest of the group members, introduced ourselves, and yeah, that's just how it is. Honestly, it's all about who you know, like reach out to different residents through LinkedIn, and yeah, I mean, there's always interest, right? Because as a resident, before fellowship, they also have to, do research and publish. So the interest is definitely there. It's just about you being able to go out and connect with them.
Sounds good.
Yeah. So Dr. Amal, mashallah, she was the one who connected with them, and like, alhamdulillah, we were able to meet him, and it's been a great collaboration so far.
Excellent. Thanks for sharing. So,
of course.
Yeah.
Yeah. Thank you, Dr. Nadir.
And for all fellows who are attending this meeting or will watch this in the future, I think the collaboration makes sense because some of you might have some time, some of you might have some experience. And for residents or fellows, for them, they want to publish, they want to get competitive when they want to go for fellowship or subspecialties. So they may have some ideas, but they don't have the time. So both of you will complement each other. They may guide you through what to do. They may give you some task, and then you have the time to complete the task. And both of you, it's a win-win situation for the fellows in this program and the residents or fellows or other collaborant from other programs. So this is great. Thank you so much for sharing, Dr. Ryan.
No, of course, Yani. By all means, guys, it's with this part of Dr. Nadir, I'm like, with your networks, it can work. And I think the other thing is like, not just in research, but as like residents, they can recommend to the board for future residents, right? So it's a win-win situation either way. Just don't be hesitant and reach out. Okay, Jazakumullah khair.
Jazakallah. Thank you so much. And speaking about LinkedIn and the social media and connection and so forth, I think I can share with you. This morning I was looking at some of the ideas and how to use AI. So let me get the screen. So this one article I was looking at this morning, and I was searching about social media using mesh term and focus on LinkedIn, for example. So I have other articles, but I looked at this one, and I looked at another one for residents in surgery. So what I did is I used ChatGPT to see if I can manipulate it so that I can get new ideas out of it and see if we can come up with some abstracts, mock abstracts. So I'm gonna stop sharing and show you how that goes. So I used Google AI, that's Gemini or BART, it was named in the past, but Gemini. So I gave the, it's called the prompt or the question. That's, I want to write an abstract about social media in geriatric, for example, training. And I give the example of what I have. So I can show you. So I just copy paste one of the abstract that I found interesting. And I asked the ChatGPT or the BART in this case to write the abstract for me. It's a mock abstract. So it will give me a title, and it will give me the background, objective, methods, and so on. And out of it, I can go back and build my own project. So this is the idea, or this is the research question. How can I start working on this from scratch? So this will help me identify some of the references for the background. So maybe I can find a couple of articles looking at this or talking about this. So I can build up a good background for my question, why my question is important in this area, and how can I come up with some new project for the literature, so I can add some new information. The objective will be your aim of the study, so you can modify that. The method can be different methods. In this case, I can use, for example, systematic review, the one Mayra was just mentioning the method, how to do that. And then I can do other type of reviews. And as I get the results, I can build up my conclusion or my take-home message from my project. So this is one way to use AI to build up an abstract, or maybe if you want to extend it as a manuscript, you can do that. So it's easier done because you don't have to invest a lot of money or time getting clinical data or studies that might be available or not available for you. But all this will be available as far as the social media consent. So this is one way of doing it. I come up with two abstracts doing the same method using AI. So some of you might be interested in publishing something in the area that you are interested in, let's say in psychiatry or in neurology or in pediatric. So you will take that abstract. I use one from residents in surgery, so I can modify that to whatever area that you are interested in, and see what mock data or mock example they will give it to you, and then you go back, you build up your research. I think this is in the past they use it in other field like psychology. They call it reverse psychology. So you come up from the problem or the results, and you go back. In nursing homes, we use similar method. We call it the fish bone analysis, where we can look at what happened and go back to why this happened. For example, an older patient had a fall in a dining area. So this is the result. The patient, we found the patient on the floor. So we'll get some data about what happened. So we'll ask the nurse aide or the dietitian or nurse, whoever witnessed the patient, and we'll get information from the patient and see what led to that fall. Is it the patient did not see what's going on because he did not have his eyeglasses on? Is it because of weakness? So anything related to the patient or patient abilities or assistant devices. Then next is the environment. Was the floor wet, or maybe there are some cables or wires on the floor, so he tripped? Was it the lighting? Maybe the area is dark for the patient, something like that. So we pull all the data and put it in, they call it fish bone diagram. I'm going to show you something like that. So fish. So in this area, like a fishbone diagram, how to use it for root cause analysis. So you come up with what happened and you go back to put some of the possibilities, like the patient themselves, the environment, the medication, and in each bucket or each group, then you identify certain things. So the patient, the ability to use eyeglasses or hearing aid or a cane or something, or their own medical condition. Maybe he had orthostasis. So we'll look at the blood pressure sitting and standing, and then go back to the medication. Was it cause of change in the medication for blood pressure, or adding other medication on top the blood pressure, for example, diuretics with other components that can enhance that? Or maybe he was not drinking, maybe it was hot day. So this is one way of looking at things backwards and building from that. In the case of nursing home, we want to prevent falls from happening. So this is our objective. In the case that I presented to you, the goal is to build up a research idea, a research question, and then you can start building up your abstract. You can send it to a conference for a poster, or you can extend that to a manuscript that you can submit to a journal as an article. So you can use the AI as a tool that will help you when you read the literature, see what you can modify using the AI and come up with new ideas. Thank you. Anyone used AI in your life in general or research in particular?
Yeah, it fairly gives a good hold of topics or whatever breakdowns we want in the subtopics. So sometimes it's helpful. So
Yes.
I used it for a certain topic. However, that project didn't go through. But yeah.
Excellent. Thank you so much for sharing. Anyone else?
Yes, Dr. Nader. I've used it multiple times in different projects. It's usually very helpful when you're trying to outline what you're going to write, let's say in an abstract or something, and then you can write from there. It's also very useful if you want, let's say you wrote something and you want it to sound more professional, more that you could actually be in a research, let's say manuscript or something. So I think it's very helpful while you're writing, not dependent on it 100%, but it's something that you could depend to kind of improve your writing in a way.
Excellent. Yes, I completely agree. Thank you.
Thank you, Dr. Ned.
Yeah, I've used AI as well, Dr. Nader. I used it at the end, so almost as an editing tool. It helped me fix the word count, because depending on where you apply, there's certain word counts. So it helped me take out unnecessary words and characters. So that was really useful, because you don't realize how redundant some things are. But yeah, totally put into perspective. So I was very happy with that.
Excellent.
It helps. It helps again as a grammar, like a grammar check, because when you put what you want to say, sometimes the way you want to say is not the properly professional, and it helps you to correct that, to make it sound more professional, to correct your grammatical mistakes. And so this is like a double check from like another pair of eyes. But always you have to give it your the feeling of it, because it sounds too automatic, and so you have to put a little bit of yourself in what it types. But it's really good.
Yes. Thank you so much for sharing, Dr. Mayra. Go ahead, Dr. Lima.
Oh, hi everybody. Dr. Nadir. Sorry, I'm driving. If you can hear me, I just have one question. So we're just working on a new project on GI and geriatric community. We're trying to organize the group now. So my question is, what are like the areas that we should focus when we do we use AI for any systematic review or any research project? So is it going to be like filtered when you submit it for a journal or something? Is there any way that we should pay attention when we use that AI draft to our own project?
Yeah, so that's a great question. So for your projects, when you come up with the idea and then you start working, if you are using AI as a tool to help you, some of the journals, for example, they prohibit that from happening. So any use of AI in your manuscript, they will not accept. On the other hand, there are other journals that accept the use of AI as a tool, but they want to be clear that the authors must include in their manuscript that they use the AI and how did they use that. For example, we use it for helping with language correction, for example, grammar and whatever. So it's a minimum use, or we use it for finding duplicates in data analysis, something like that. So there are some tools focused on the use of AI to help you get your task done without doing it for you as an author. They don't want you to get an AI write the whole thing for you. As I showed you, it can write a mock abstract for you, but it's not acceptable to use that, the whole thing, and submit it to the conference or to the journal as an abstract that you wrote, because in fact you did not. So that's the catch, or that's the worry from the journal. So they want you to mention that you used AI and in what capacity, what areas did the tool help you. If you clarify that in your manuscript, for example, when you're submitting to the journal, they will accept that. And more and more journals are accepting AI as a tool that authors will be using in the future. So my suggestion is when you write something, look at the journal that you are targeting. If they are not accepting, then don't use it. If you are going to use it, then search for journals that accept AI.
Okay, thanks so much, Dr. Nadia.
You're welcome. Thanks for the question. Any other comments, suggestions, questions?
Assalamu alaikum, Dr. Nadir.
Go ahead, Dr. Sarah.
Yes, we are from Red Team. We make like subgroup. We have a systemic review research. We held like 2 or 3 meetings. We come out with topics. We agree on the topic. We just want from you, Dr. Nadir, to see how to proceed.
So you already came with a topic, you have the team, and you are asking for the next step, or I didn't get the question here.
Yes, is it okay to proceed, or we have to like review the topic with you? And yes, basically what next? Like,
so I'll be happy to do that. Most of the time what we do is we will ask some of the senior fellows available, maybe Rayan or maybe Nidhal or Sulafa or someone who did some work similar to your work, maybe you can approach to them, and then they can or how to do the next steps. If Brian or Srafa or Neda, anyone wants to check?
Yes, I contact Sulafa. She is a team leader, and she asked me if I can just tell you about the research. I don't know, but I contact her first. Yeah, my team leader. Yes.
Yeah, so you can send me the proposal or the idea, and just send me an email. We'll review that and feedback as far as what's the next step and how we can achieve that.
Okay, thanks so much.
Thank you so much, Dr. Sarah. Good job of a new project.
Hi, Dr. Nidhal. Assalamu alaikum. كل عام وانتم بخير. Yeah, Dr. Sarah contacted me and I asked her to propose her idea and research to you. And if you are accepted or agree with us, we can proceed.
Sure.
Thank you so much.
You're welcome. Thank you so much for helping. Any other comments, questions, suggestions, updates? If not, I'd like to thank the team of today, all the presenters. Thank you, Dr. Marina, for helping us with this meeting, and your team. And thank you all the presenters for great presentations. Thank you all who attended this meeting today. And thank you to those who will look at the recording later. I wish you all the best and good luck.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you.
Thank you, and Eid Mubarak to you all.
Thank you.
Yes. Thank you so much, Eid Mubarak.
Thank you.
Thank you, Dr. Nader.
Thanks. Have a good day. Night.